you see a big pupil on the left side here. This is the left, this is the right, as if you're looking at somebody, okay? This could also be the pupil that has hippus, like it's gonna, well, they might both, this might blow out faster. You shine a light in it and it kind of comes in and blows out pretty fast, right? Basically, what you're saying are the sympathetics are higher on this side than they are on the right, okay? So that means that if you go down to this spinal column through here in the IML portion, we're gonna call it, that the IML is higher on this side, you know, than it is on this side. So if the IML is high, or the sympathetics are high on one side, it is often because the parasympathetics are not inhibiting it. So if we look at like what the parasympathetic areas are in the brain, then we know it's, and we're gonna talk about it in reference to this, but it's the cortex, frontal lobe, parietal lobe, temporal lobe areas, and it's the pontomedullary areas, the cerebellum, and the vestibular connections to that. We skipped the midbrain because the midbrain is more mesencephalic through here, right? We have this mesencephalic reticular activating system that fires down to stimulate this system. So this actually comes down to activate the IML. But we have these other two things, the cortex and the brainstem, that fire down to inhibit it, okay? So if the pupil is bigger, we have more hippus, or blood pressure is higher on this side. You see that too with people. So let's just write that out. So it could be sympathetics higher, could be hippus, could be your cortesia, could be higher blood pressure on the left side. It could be, you know, you're not, you know, they're getting more sweating on the left side, like the palmy, cold and clammy hands type thing, all kinds of things, like anything sympathetic related. Thereby, there must be something going on here. So if this is not, this inhibits this, pushes, you know, dampens, puts the brakes on that sympathetic, or it's right here, also puts the brakes on the sympathetics. These guys are involved in this same process through here. We're going to kind of link these all together. So if one of these is unhealthy, then you're probably going to see sympathetics start to rise up, because they both have to work to do that. So the reason we're only saying that it's the left or the left here is because that big pupil on this side, it must be one of these on the same side of the big pupil. What we don't know now is which one it is yet. One way that we do this that's pretty simple is you can perform lower extremity complex movements on one side or the other to determine who's who. So if we perform, let's say, left-sided lower extremity complex movements, then what's going to happen is that pathway goes up through the brain stem on the left side to the opposite mesencephalon, to the opposite cortex primarily. That tells us if that makes that better, if that improves that, we can hold that better, that gets smaller, or any of these things get better, then we know that it's more primarily this brain stem on this side. If we do the other side, if we do the right side lower extremity complex movements, and that gets better, well, that means it's the cortex, because this comes up to the right lower brainstem, crosses over to the left mesencephalon, and then up to the left cortex. So that means it's actually cortical versus brainstem, okay? And there are other things we could do to stimulate this. We could do proprioceptive activity. You could do distal adjustments on the upper extremity or lower extremity. You could do, you know, percussive work. You could do different types of neurological things. But this is an easy way to just understand it quickly. We use, in our tilt table, we use somatosensory evoked potential, the SSEP. So if we did SSEP stimulation to the right trigeminal nerve through the face, and it gets better, we know it's cortex. Same idea. If we do left SSEP and this gets better, one of these V1, V2, V3 areas, then we know that it's lower brainstem. We could do it to the left vagus. You could hit the vagal nerve. Same idea. right? So it matters which side, but you have to know that the sidedness is in line with the big pupil or the other findings, and they inhibit this, and you just have to determine which one is deficient. You had some questions.
Yeah.
Or did that answer?
That pretty much answered it. Just the beginning of finding the sidedness of which one's not really inhibiting. The pupil kind of answered it for me, or the hippus, or the blood pressure. I'm like, which side first, and then you can determine like which complex movements.
Yeah, because I won't really know, right? I'll know based upon other findings of my testing, because I'm gonna already have an idea, like we talk about, right? If I turn their head to the left and things get easier for them neurologically, then I'm gonna think, well, maybe that left brainstem is more involved. I'm not gonna go off that one thing, but more things like that. Maybe they have agraphesthesia on the left side. Maybe they miss their nose. Maybe they have parietal drift on the left side, that type of thing. Maybe you have a dysautonomia on the left side. You're like, wow, all these findings are telling me there's maybe this pathway that comes from the left side of the body through the left lower brainstem, cerebellum, vestibular aspect to the right mesoderm, to the right cortex. That seems to be more involved. Let's do that first, see if this helps. Oh, that helped. Great, that's what it is. You know what, that didn't help. Actually, the right side helped. Well, then there's probably two different pathways going on, two pathways affected. So the more the autonomic impact of what's going on initially is going to be from a different pathway. So we have to focus on that one first, because we want to fix autonomics first, because we need to have good blood flow to the brain in order to heal it. Right? So if you don't have a good fuel and oxygen to the brain, we can't create the neuroplasticity we want to in the same rate that we would do that.
Okay. If there was a pyramid of priorities of which to start with, you would say the base of the pyramid would be the autonomics.
Yes.
And then above that, would you say vestibular? And then above that, would you say eyes or?
Yes, exactly. So the autonomics you would affect first, like you said. The vestibular system and the autonomics are often connected, because often the autonomic stuff is actually due to vestibular issues, because of the way that the vestibulosympathetic pathway comes directly to the autonomic nervous system. But yes, exactly. Then we get to vestibular. Then we get to eyes later, because then we're pushing the brain harder. But now we have a better function of the brain, not only spatially, vestibularly, but we also have good fuel delivery. So now we can change it faster and faster, and they're ready for it. We're not pushing it on empty. We're not on E.
Differentiating the difference between more of a vestibular otolithic component rather than a brainstem or cortical.
You got it. So, vestibular otolithic is kind of going to be a similar type of presentation. When you see somebody who has, one of the easiest ways to see if there's an otolithic thing is, how are they doing with convergence? Are their eyes not converging completely? Are they coming in and spasming and different types of things? Do they have like a lot of movement? Are they dizzy? Are they lightheaded through movement? They have poor spatial understanding. Do they have a lot of like tightness, dyskinesias and muscles and poor posturing and all these things where spatially they're just off, or they're swaying a ton on Romberg. So I think, there's a vestibular component, maybe this otolithic system, maybe the semicircular canals, I don't know which one yet, but typically when there's the convergence issue, there's an otolithic issue. And so the same deal is like to say, well, a lot of times, so to converge the right eye, we use the right mesencephalon. Okay, so we drew it here. So the right top part of the brainstem, the midbrain. So we just say, well, is that otolithic, or is that just the brainstem, the mesencephalon not being activated because the cerebellum or the lower brainstem on the opposite side is not feeding it good information? So we say, well, we'll do the same test. We'd say, hey, if the left lower extremity stuff helps out a ton, then it was probably more brainstem. But if it's the same side, because the otoliths move the eye inward or deviate it on the same side, then it's going to be otoliths. The right side is going to actually be helpful. So if I turn the head to the left and it gets better, it might be more left brainstem type stuff. If I turn the head to the right and it gets better, it may be more otolithic, or tilt the head, or those different types of things.
Right otolithic?
Right otolithic if you tilt the head to the right, yeah. or rotate it to the right. Anything basically that activates that system on the right side. If that starts to get better, you might be like, well, that's actually more otolithic. And then I'll drive I'll do right lower extremity complex movements. I'll do a lot of brain, right lower brainstem, right cerebellar, right vestibular, left cortical activity eventually, right body proprioceptive activity to stimulate all the pathways that are involved with that. Because remember, neuroplasticity needs temporal or spatial summation to really form, right? To form these new connections in the brain to restore these pathways of function or the health of the brain. We need to create more connections. And so we can do it by doing it repeatedly over time, for sure. And then we can also do it by doing something kind of big. And by doing it big, it's more like doing lots of similar types of stimulation to the same region through different mechanisms that create a large change. And we still do that over time too. And you combine those two things and you get a completely revamped and reestablished pathway in the brain. And then they're back to normal. And usually you see these things, they don't come back because you just restored the pathway. And the brain already knew how to do it once. Once you get it to a certain point, it takes it the rest of the way. And we do it a little bit more to make sure we tie the bow on it, but it's not like you have to continue to do exercises the rest of your life or different types of things. If you do it long enough and you do it the right way, like we do, you don't have to keep doing it.
Gotcha.
It's done.
The stimulating right otolithic, would you say that stimulates the right mesencephalon?
Yeah.
Okay.
Yeah. Yep.
Okay.
Yep.
Mm-hmm. I guess when I was learning it,
well,
I thought
the right, like these areas of the mesencephalon, the convergence mechanisms.
right.
Yeah.
So not the lower brainstem parts, but the
Well, you're still going to get this activity going.
with the right.
Yeah, to the contralateral side, because you're still going to go through the brainstem. You're still going to hit that.
Mm-hmm.
It's just that this is going to come up more exclusively
Okay.
to that area.
Mm-hmm.
So you're getting two different things. In the brain, there's always more than one thing activated. It's never only one side.
Mm-hmm.
Because in order to like move my left arm, I have to brace my right side, stabilize, right? So you have to have these things that it's just, as Dr. Carrick explained it to me, it's like a 60-40 type relationship. But in the brain, it knows it. So like if you stimulate the right thing, you'll see it come in.
Mm-hmm.
So when you stimulate that right side, that should, regulate itself.
Yeah.
Mm-hmm.
Nice.
Yeah.
That's all I had.
Okay. Yeah. This one gets a little more confusing, but it's actually really simple. Just otoliths on the right side, stimulate the right eye coming in, otoliths on the left, do this.
Mm-hmm. With a convergence spasm?
Convergent spasm, yeah, that usually is like really overactive mesencephalon. Like we might call that close to threshold, right? So, a lot of times you need to calm that down first, obviously. You would never do convergence type activities with those types of people. Likewise, with convergence deficiency, I don't start with convergence activities with people. Mm-hmm. I know that in some fields they do, but you don't want to take something just because it's weak and drive it more. Because if you take this and just keep pounding this thing, that actually is not the problem. It's something beneath it. What do we call that in neurology? We call it presynaptic, meaning it's something that's feeding into it along the pathway before it gets there. So you're just spending all your time with this thing that's not working right and not going to work right because this thing down here isn't working. So you're kind of missing the problem there. So with a convergence deficiency, a convergent spasm, though, to your question, you wouldn't want to drive that more because it's already overdriven. So it's not being inhibited by these things. The IML is not being inhibited, but the mesencephalon itself, because the cortex fires down directly to inhibit this little guy too. It controls that. It also activates it, but anything that activates also inhibits, right? So there's some kind of dysfunction a lot of times in that frontal mechanism, and a lot of times it comes from the otolithic being overdriven, right? You see this with people who self-manipulate, right? They get that hyperkinetic activity. What are they doing? They're overstimulating that mesencephalon through those, because the mesencephalon is anterior portion, right? The ventral portions, that's where all the motor stuff comes through. Where are these guys? Where's cranial nerve 3 in there, right?
It's right there.
Yeah. So what happens with that, when you self-manipulate, you overdrive the mesencephalon in these areas, which overdrives cranial nerve 3, which brings the eyes in, which creates a spasm, which then creates an hyperkinetic stimulation to the autonomic nervous system. So now you're getting people who are getting POTS and fainting and these types of things because and anxieties and elevated heart rates and all these things because they're over manipulating these joints in the neck or the lower back or different areas that are creating a really higher rate of function, or not in a good way, but a too high a rate of discharge in this area, which is screwing up the output to other areas of the brain.
Mm.
That's really important because a lot of people, younger people, do it.
Mm-hmm.
Now, in chiropractic, is a little very different, right? So we're only working on areas of the brain, of the spine that are not moving enough. They're stuck. So we have to get them up too, because that can also cause a lot of these things too. It's the same mechanism, except the opposite of it. It's actually like a low input to the brain. So then that takes the brain and depresses it. So the autonomic nervous system is depressed and the cortex is depressed, and we just don't function as well as we can because we're not getting the stimulation through the brain through these mechanisms. And so we actually have a lower function. That's where you get into the hypokinetic. The eyes aren't coming in enough, right?
Yeah.
So that's where the convergence, like you can base so many things foundationally off convergence. And you see that I do that in practice a lot, right? It's like my first breadcrumb. I'm like, what are they doing with convergence? And that leads me to my next thought. I say, well, the right side isn't coming in. So you see me start doing stuff. I look at other things. I gather some evidence. And I'm like, okay, I think now that this isn't coming in because of X, Y, and Z pathway. And then we do more stuff and we test them. We're like, yep, that's it. Sometimes it's not exactly how we kind of think it's going to work. So we find that other mechanism. And then we do all kinds of tests that support that and stuff. But the low versus high, I mean, you can still tell from this. And most of these kids that are self-manipulating, you come in and they got that spasm. And then they also have these other anxieties and, other, symptoms and sympathetic activities that are, bothering them, the POTS and stuff.
Mm-hmm.
Yeah.
Definitely.
Mm-hmm.
With the light sensitivity and like sound sensitivity, that's kind of the same. Overactive mesencephalon, because
That's
all
right.
the information goes in there.
Yeah, great point. Yeah, light and sound. Probably what I want to use. Yeah, light and sound come in right through this mesencephalon too. Just like we're saying that movement comes through there too. So, these are the people that have can't handle light and sound, a lot, whether it's a lot of different light and sounds, at the same time, or just bright lights or different things. They can't handle that. And these people often, this is migraine sufferers. These are migraine sufferers. These are post-concussion people. These are, maybe those kids who are, people we're talking about who self-manipulate a lot, they're gonna have some aspect of that, but really it's your concussion and post-concussion people and your migraine headache people. And we can fix it the same way. It's a similar mechanism of, we don't know where the lesions are exactly. That's where we have to do our exam and figure that out. But once we figure out where the problems are below in the brainstem, then we can figure out, or up higher, we can figure out what isn't feeding into this properly and causing it to be dysfunctional in the mesencephalon that is creating this misinterpretation or lack of gating of light and sound coming in. We're not processing it quickly enough is really the simplest way to say it. We're not processing it correctly, so it stimulates things in a hyperkinetic way. As it's already overdriven in here, like you said, or too close to threshold, we might call it sometimes.
And hypermobile people would be too much movement, but we adjust the hypomobile, the restrictions, basically.
Exactly right. Exactly right. This is also why you see people with EDX, right? Ehlers-Danlos, type stuff. You see them with POTS and different types of things because they have too much mobility and movement, and so they get this hyperkinetic activity through here, and they get a hyperkinetic activity into here. So they get POTS. You see people with POTS and different things. They also have laxity sometimes in their arteries and, you know, connective tissue, right? It's connective tissue issues. So the arteries and veins, you know, they don't compress as well. Arteries don't compress as well as they do, so they have trouble getting sometimes blood up to the brain as quickly as possible. So
Nice.
those people, we really want a good system working through here,
Oh, yeah.
because we don't want any errors for them.
Kind of going off of that, could that affect the baroreceptor reflex for
Yeah.
connective tissue and stretch?
Absolutely connects, or it would affect that. That's a great point. And that baroreceptor reflex that lives in the carotid artery, right? Or the baroreceptors do, and then they talk to that autonomic nervous system, and that this is the carotid, if you will. It's at the bifurcation, but there's like this communication back and forth that occurs through that lower brainstem in those little receptors in here. That basically, when the blood vessels are expanded, they send a signal in to say, "Hey, slow down, IML," because we're getting too much pressure, you know, getting too much blood basically up to the brain. We don't need more. So we say slow heart rate down, slow blood, your artery constriction down, and then it kind of regulates. And then what happens is then as it kind of becomes lax and slack, it sends another signal that says, "Hey, speed it up." So it sends a different signal after that. So it kind of goes back and forth, sending a dampening signal and an increasing signal back and forth. So it's like putting the brakes on, taking them off, putting the brakes on, taking them off, all day long, just so we regulate. And we have to do that, right? Because we know our arteries have to squeeze and dilate. So we have to put the brakes on and take it off. Put the brakes on and take it off. And we're not switching between parasympathetics and sympathetics with skeletal blood vessels and stuff and those types of things, because they are only innervated by sympathetics. So we're just really putting the brakes on or taking them off. We're saying speed up IML or slow down IML. But that system's very important, but it's more regulated through the autonomic network through here, which is regulated by a lot of other stuff.
Gotcha.
So it's in the connective tissue people, you know, it'd be a question of like how much is that involved? Probably a decent amount, you know. But with regular people who don't have connective tissue disorders, this becomes very affected, but it's not necessarily the thing that's causing it. It's oftentimes this is actually the baroreceptor reflex has to do more of the work, because the vestibular sympathetic reflexes and the trigeminal and all these other things that are contributing to aren't working as well. So this actually has to do double time it and do, you know, everybody else's work too. So it can't do anything really well, but it keeps you going. It just is not going to be efficient. Yeah.
Makes sense. Do you ever think about right vagus nerve controlling more heart rate, the left vagus nerve is more like heart contractility, or is that?
Oh yeah, like SA versus AV node and
Right.
stuff. Yeah,
Right.
yeah, that factors in too.
Okay.
Yep.